What if I told you that to save your skin from being like completely permanently destroyed, you have to apply a medication that is actually world famous for destroying skin?
Yeah, it's a massive contradiction. And honestly, it's the exact reason why so many people get stuck in this terrible cycle of fear, undertreatment, and ultimately, preventable physical damage.
Right. So, welcome to the deep dive. And if you are listening to this, chances are you already know the profound agony of a lichen sclerosus flare up.
Which is, yeah, it's intense.
It really is. And we're going to assume you already know the basics, right? Like, you
Yeah.
know the visual changes, the intense itching, the massive impact it has on your daily life. You really don't need a textbook definition of what a vulva is.
Exactly. What you need is clarity on the actual treatment protocols.
Hmm.
Because let's be honest, the landscape of online advice is incredibly murky.
Oh, it's a mess.
The forums are just filled with contradictory advice, especially regarding ultra-potent topical steroids. So today, we are cutting through the noise.
Yes, we are.
We've basically synthesized a massive stack of dermatology guidelines. So we're talking protocols from the British Association of Dermatologists, European guidelines, and specialized vulvovaginal resources.
All to answer one very specific question, which is how do you safely taper ultra-potent topical steroids during lichen sclerosus remission?
Right. How do we get off this stuff safely?
Okay, let's unpack this, because to really understand the taper, I feel like we first have to understand the opponent here.
Yeah, you have to know what you're fighting.
Right, and when we look at the pathology in these sources, lichen sclerosus or LS, it isn't just, a surface-level rash. Like, what is actually happening biologically when a patient is in the middle of a flare?
Well, the battle is actually happening much deeper than the surface. So LS operates in a way that is strikingly similar to an autoimmune condition.
Okay.
The immune system's T cells just become totally confused. They migrate down to the very bottom layer of the epidermis in an area called the basement membrane,
And so they go all the way to the bottom?
all the way to the foundation, yeah. And they basically launch an attack on the body's own proteins right there.
So the immune system is essentially dropping bombs on its own foundation.
That is a great way to visualize it, honestly. And the collateral damage from that attack, it fundamentally alters how the skin behaves.
How so?
Well, the inflammation triggers these cells called fibroblasts to just go into complete overdrive. And, fibroblasts are responsible for producing collagen.
Right, which we usually think of as a good thing.
Usually, yeah.
Yeah.
In healthy skin, collagen provides elasticity and strength. But in LS, the fibroblasts produce massive, dense bundles of abnormal collagen. It completely alters the architecture of the tissue.
Oh, wow. Which explains the visual and physical symptoms.
Exactly.
Like the loss of the inner labia, the fusing of tissues, the burying of the clitoris. The anatomy is literally being remodeled by this abnormal collagen.
It is. And that brings us to the gold standard of treatment, which is ultra-potent topical steroids. Specifically, clobetasol propionate 0.05% ointment.
And this is where the panic sets in for so many patients.
Oh, absolutely.
Because we are drilled from a young age to fear strong steroids. We are told, they cause skin atrophy, they thin the skin, they make it fragile. So why on earth are global guidelines mandating the use of the absolute strongest category of steroids on the most delicate, highly sensitive areas of the human body?
It sounds crazy, I know. But to answer that, we actually have to look at the work of experts like Dr. Jill Kraft, who is heavily cited in these resources. She completely reframes this whole issue.
Okay, how so?
Well, she points out that the skin you are treating is no longer delicate because of that massive overproduction of collagen we just talked about. The tissue is thick, rigid, and deeply inelastic.
So it's essentially biologically armored at that point.
It is. Dr. Kraft uses this really brilliant analogy. She says when LS skin tears, which causes that excruciating pain patients know all too well, it is not like fragile tissue paper tearing.
Right.
Because it has lost all its elasticity, it is actually like a concrete sidewalk cracking.
A concrete sidewalk cracking? Wow, that changes everything about how you view the medication.
Right. When you apply clobetasol to active lichen sclerosus, you aren't thinning healthy tissue. You are melting away that concrete-like inflammation.
I see.
The steroid is a highly targeted weapon. It shuts down the T-cell attack at the basement membrane, halting that abnormal collagen production. You basically need something ultra-potent just to punch through the concrete.
But, okay, if the skin is literally acting like a thick slab of concrete, Getting the medication all the way down to the basement membrane sounds like a massive logistical hurdle.
It is the biggest hurdle, actually.
Because the sources we reviewed are adamant that most treatment failures aren't because the steroid is the wrong drug. They fail because in the application method, right?
Yes, the clinical guidelines outline a very specific art to the application. You cannot just dab the ointment on dry skin and expect it to work. The protocol requires serious preparation to achieve remission, starting with a soak. The guidelines universally recommend soaking the affected area in warm water for 15 to 20 minutes first.
So taking a bath, basically.
Yeah, a bathtub, a sitz bath, or a warm shower works.
Mm-hmm.
And then gently patting the skin dry.
I want to pause on that for a second because the rationale there is purely mechanical, isn't it? Like if you put a heavy, thick leather conditioner on a bone-dry, stiff, dirty boot, it's just going to sit on the surface.
Right, it ruins your socks and does nothing for the boot.
Exactly. It won't absorb. You have to prep the canvas to allow the moisture in.
That's a perfect analogy. The warm water hydrates the outermost layer of the skin, the stratum corneum. It softens that rigid, thickened tissue and temporarily expands the cellular pathways.
So you're opening the doors.
You're literally opening the doors to allow those heavy ointment molecules to travel down to the basement layer where the inflammation is actually happening.
Okay, so once those doors are open, the guidelines get very specific about the amount. They use the term fingertip unit, which translates to about 0.5 grams. So basically a pea-sized amount.
Very small, yeah.
But they specify that this single pea-sized amount is for the entire affected area. That includes the vulva and the perianal skin if the LS is spread there. That sounds like barely anything at all.
It is a minuscule amount, I mean, truly. But remember, this is an ultra-potent formulation. More is not better here.
It just sits there.
Yeah, more simply pools in the surface and actually increases the risk of systemic absorption and unwanted side effects. The efficacy doesn't come from a thick layer, it comes from friction.
Friction.
Yes. The protocol mandates gently rubbing the ointment into the skin for 90 to 120 seconds.
2 full minutes of active rubbing. I feel like that requires a lot of patience.
It really does. But the gentle massage is absolutely non-negotiable. It physically forces the active steroid molecules deeper into the hydrated tissue. A quick swipe just will not reach the fibroblasts.
Okay, that makes sense.
However, the guidelines strongly warn against rubbing so hard that you cause micro tears or provoke scratching. Breaking the skin can trigger a secondary, highly itchy condition called lichen simplex chronicus, which just complicates the entire treatment process.
Oh, that sounds awful. Which actually leads to a really practical question about the medication itself. Ointments are notoriously greasy, right? They're messy. They ruin your underwear.
Oh, definitely.
So from a purely user-friendly standpoint, wouldn't a cream be much easier to rub in for 2 minutes?
A cream vanishes way faster, yes. But dermatologists vastly prefer ointments for the anogenital region for a very specific pharmacological reason.
Okay, what is it?
Creams are emulsions that contain a pretty high percentage of water. And whenever you introduce water into a product, you create an environment where bacteria and molds can thrive.
Ah, meaning you have to load the tube up with chemical preservatives and stabilizers?
Exactly. And compromised, inflamed skin is incredibly reactive to preservatives.
Right.
So applying a cream to an active LS flare significantly increases the risk of developing allergic contact dermatitis. You end up treating the LS, but causing a secondary allergic rash that burns and itches just as badly.
It defeats the whole purpose.
Totally. Ointments are greasy because they are petroleum-based, they contain virtually zero water, require very few preservatives, and they act as an occlusive barrier, locking in the hydration from your 20-minute soak.
Okay, so we've prepped the canvas, we're using our pea-sized amount of ointment, we're rubbing it in for 2 minutes. Let's say a patient does this daily for a couple of months. The concrete finally melts.
Yes.
The skin becomes soft, the intense itching stops, and the architecture of the tissue stops fusing. Remission is achieved, the fire is out.
Best case scenario, yeah.
But the instinct for anyone in that scenario is to put the fire extinguisher away and stop the treatment completely. But based on our sources, that introduces a completely different biological problem, doesn't it?
It really does. It is the most critical juncture in the entire patient journey. The goal shifts from fighting a raging fire to maintaining a permanent fire watch.
A permanent fire watch?
Yes. The standard European and UK guidelines advocate for a highly structured 3-month step-down taper.
Walk us through the math of that 3-month schedule. How does it work?
Okay, so month 1 is daily application, once a day for 4 weeks.
Got it.
Month 2 steps down to alternate days, so every other day for 4 weeks, and then month 3 steps down again to twice weekly for 4 weeks.
Okay, and after month 3.
You enter the lifelong maintenance phase, twice a week, indefinitely.
Okay, let's dig into the why here. Because if I'm in remission, my skin feels totally normal, the symptoms are completely gone, why do I have to subject my body to a heavy-duty, ultra-potent steroid twice a week for the rest of my life?
It's a tough pill to swallow, but lichen sclerosus is incurable. The autoimmune-like T-cell response doesn't just pack up and leave, it is merely suppressed.
So it's just sleeping.
Right. The inflammation is always simmering beneath the surface. If you stop the medication completely, those fibroblasts wake back up. The concrete starts pouring again.
And the really terrifying part of the clinical literature is that the concrete often pours silently, doesn't it?
Yes.
A patient might not feel the intense itch right away, but the architectural changes, like the fusing of the labia, the scarring over the clitoris, they can quietly resume until the physical damage is irreversible.
Preventing anatomical loss is crucial, absolutely. But there is an even more severe consequence to untreated LSS. Chronic unmanaged inflammation drastically increases the rate of cellular turnover.
What does that mean for the patient?
Well, when cells are constantly dying and rapidly regenerating in a highly inflammatory environment, the risk of DNA damage skyrockets.
Leading to cancer.
Exactly. Specifically, squamous cell carcinoma of the vulva. The data shows a lifetime risk of less than 5% for LS patients.
Okay, that's small but significant.
Very significant. But proactive, twice-weekly maintenance therapy with a topical steroid has been clinically proven to effectively maintain remission and significantly neutralize that exact risk of malignant change.
Wow. So a pea-sized amount twice a week is actively protecting you from cancer.
Literally, yes.
And the clinical resources suggest a very manageable rhythm for this, right? Like, use your steroid ointment on the weekends, say Saturday and Sunday nights.
I like the weekend routine. It's easy to remember.
Yeah, and then on weekdays, use a plain inert emollient, things like coconut oil, hydromol, or just a basic medical barrier ointment to keep the skin hydrated and protected from the acidity of urine.
It normalizes the routine, which is key. And the guidelines provide a really brilliant objective metric to ensure you are tapering correctly. It is the golden rule of quantity.
Oh, that's right. The tube size rule.
Yes. A standard 30-gram tube of ultra-potent ointment must last you at least 3 to 6 months.
30 grams stretching over half a year, that really grounds the whole idea of a pea-sized application.
It really does. If you are burning through a 30-gram tube in, say, 6 weeks while supposedly in the maintenance phase, or if you find yourself needing to apply it 4 times a week just to keep the itching at bay.
That's bad, right?
It's a glaring red flag. It indicates the disease process is not actually suppressed and an immediate medical review is required.
But let's flip that scenario for a second. Let's look at the patient who is just terrified of the symptoms returning.
Very common.
They ignore the taper guidelines entirely. They use the clobutahase every single day for 8 months, and then their prescription runs out, or maybe they just suddenly decide to quit cold turkey. Biologically, what happens to the skin in that moment?
Oh, man. That patient is about to crash headfirst into a devastating complication known as topical steroid withdrawal, or TSW. It's sometimes referred to in the literature as red skin syndrome.
This is the true danger zone. Explain the mechanics of why the skin reacts so violently to suddenly losing the steroid.
Well, when you apply an external ultrapotent steroid continuously for months on end, the body senses that massive influx of synthetic cortisol.
Right.
In response, the skin cells downregulate their own natural glucocorticoid receptors. The skin essentially becomes addicted to the external steroid to regulate its normal functions, particularly the constriction of blood vessels.
So when you abruptly remove that external steroid,
The blood vessels just wildly dilate. Nitric oxide floods the tissue. The skin completely loses its ability to control inflammation.
oh, wow.
And the symptoms of TSW are just agonizing. We're talking a deep, burning redness, severe peeling, and skin that literally oozes serous fluid. The nerve endings are exposed, causing intense pain and severe sleep disturbances. Patients often say their skin feels like it's actually on fire.
Visually, the sources note some very specific markers for TSW too, like the red sleeve sign, where the severe redness abruptly stops exactly at the boundary line of where the steroid was historically applied.
Yeah, it's very stark.
Or they mention elephant wrinkles, which are these thickened, deep folds of skin. But this creates a massive diagnostic puzzle for the patient at home, doesn't it?
It's very confusing for them.
If someone stops their medication and suddenly they're in total agony, How do they know if they're experiencing topical steroid withdrawal or if their lichen sclerosus is just flaring up with a vengeance?
It is frequently misdiagnosed, honestly, even by general practitioners. But the visual cues are the primary differentiator here. Lichen sclerosus flares are characterized by pale, white, thickened, crinkly skin, and crucially, LS inflammation is strictly localized to the specific anogenital tissues.
Right, the localized white concrete.
Exactly. TSW, conversely, presents as a bright red, swollen, intensely burning area. And the real hallmark of TSW is that the redness and burning often spread beyond the initial treatment area, cascading onto surrounding healthy skin.
So it moves.
Yeah, it spreads. The oozing and shedding are also characteristic of TSW, not LS.
So generally speaking, white, crinkly, and localized points to an LS flare. Bright red, burning and spreading points to TSW.
Broadly speaking, yes. And the threat of TSW is the exact biological reason. Clinical guidelines strictly cap the continuous daily use of ultrapotent steroids at 2 to 4 weeks.
You can't just stay on it forever.
No, you use the daily dose just long enough to break the back of the inflammation, and then the taper protocol is absolutely mandatory to allow the skin's natural receptors to recover.
Okay, let's bring this back to practical application then. Say a patient does everything perfectly. They followed the 3-month taper. They are on their twice-a-week weekend maintenance. Their 30-gram tube is lasting 6 months.
A model patient.
Right. But the human body isn't an algorithm. Out of nowhere, the intense itching and the white patches return. What is the protocol for troubleshooting a flare-up during the maintenance phase?
Well, the first step is just acknowledging that flare-ups are an expected reality of living with a chronic autoimmune condition. They do not mean you have failed.
That's important to remember.
Extremely. The standard clinical protocol is to basically temporarily reverse the taper. You step back up to applying the steroid daily for 1 to 2 weeks until the symptoms are completely resolved.
And once the flare is suppressed, do they have to slog through the entire 3-month taper schedule again?
Usually no. Once the active flare is neutralized, you can drop right back down to your baseline twice-weekly maintenance dose.
Oh, that's a relief.
Yeah, but there's a hard boundary here. Do not stay on that daily rescue dose for more than 4 weeks. If daily application for 4 weeks hasn't resolved the symptoms, you really need to see a specialist.
Because the underlying issue might not actually be the lichen sclerosus, right?
Exactly.
The sources point out that skin treated with local immunosuppressants like steroids is highly susceptible to secondary opportunistic infections, like a massive yeast infection, such as thrush, or a bacterial infection, which can actually mimic the intense itching and pain of an LS flare.
It happens all the time. And if you blindly keep applying clobetasol to a yeast infection, you are just feeding the problem. But, there's another scenario too. Sometimes it is an LS flare, but the ultrapotent steroid has simply stopped working for that patient, or they have developed a severe allergy to the ointment base itself.
Which we talked about earlier, so what are the alternatives when the gold standard fails?
The second-line defense relies on a completely different class of medications called topical calcineurin inhibitors. The most frequently prescribed are tacrolimus 0.1% ointment or pimecrolimus 1% cream.
How do calcineurin inhibitors alter the mechanics in the skin compared to steroids? Like, what's the difference?
Think of steroids as a blanket fire retardant.
Right.
They suppress multiple inflammatory pathways all simultaneously, which is why they carry the risk of thinning normal skin over time. Calcineurin inhibitors, on the other hand, are highly specific snipers. They penetrate the skin and specifically block calcineurin, an enzyme that activates the T cells. By stopping the T cells, they halt the inflammation at the basement membrane, but they completely bypass the fibroblasts.
Meaning they carry absolutely zero risk of skin thinning or causing topical steroid withdrawal.
None whatsoever. They are remarkably effective.
Yeah.
But, and this is a big but, they carry a notorious compliance-killing side effect.
That burning.
Yes.
I've read patient accounts describing the first application of tacrolimus as feeling like rubbing hot sauce into an open wound. Why does it hurt so incredibly much?
It's pretty brutal. When tacrolimus first enters the skin, it triggers the local nerve endings to dump massive amounts of a neuropeptide called substance P.
Substance P.
Yeah, and substance P is basically the body's primary pain and itch messenger. So for the first few days, your nerves are just screaming.
Is there any trick to surviving that initial phase? Because, most people would just throw the tube in the trash after the first night.
I don't blame them. But yes, the specialized vulvovaginal resources offer a highly practical buffering trick. You basically apply a thin layer of plain cold Vaseline to the area before applying the tacrolimus.
Ah, so the Vaseline acts as a physical barrier.
Exactly. It slightly delays the absorption rate of the medication, which dulls that massive release of substance P and really takes the edge off the burning sensation.
That is so smart.
And the crucial thing to remember is that the burning is temporary. Once the nerves deplete their stores of substance P, which usually happens after 3 to 5 days of consistent use, the burning completely stops. You just have to endure that initial biological hurdle.
That is exactly the kind of practical knowledge that actually changes patient outcomes. Let's pull all of this together and recap the core formula for successfully tapering and managing lichen sclerosus.
All right, step 1, prep the canvas. Soak for 15 to 20 minutes in warm water to open the cellular pathways, then gently pat dry.
Right.
Step 2, the dose. Half a fingertip unit or a pea-sized amount is sufficient for the entire affected area.
Less is more.
Exactly. Step 3, the friction. Gently rub the ointment in for a full 90 to 120 seconds to drive the medication down to the basement membrane.
Give it time to work.
Step 4, the step-down rule. So generally 4 weeks daily, 4 weeks every other day, then twice a week. And step 5, the golden rule. A 30-gram tube must last you 3 to 6 months.
And finally, adhere to your twice-a-week maintenance for life. Use emollients on your off days to protect the skin barrier,
Yeah.
because that routine protects your architecture and significantly mitigates your long-term cancer risk.
It really is the definitive blueprint for preserving your physical health.
Which leaves us with one final concept to consider, zooming out from the pharmacology for a moment and looking at the lived experience of this condition. We have spent this entire deep dive dissecting the mechanics of the immune system and the skin,
Right.
but based on the sheer volume of contradictory information and anxiety present in patient communities, there is a massive unseen factor at play here.
The psychological isolation. It's huge. Lichen sclerosus is an invisible, highly intimate, and heavily stigmatized disease.
So true.
The mental toll of constantly monitoring your body, questioning every itch, and navigating a medical system that frequently dismisses or misdiagnoses vulvar pain. It is just an incredible burden.
And scientifically, that psychological burden might actually be feeding the disease itself, right?
Absolutely.
Yeah.
There is a rapidly growing body of research looking at the gut-brain-skin axis. We know that chronic systemic stress floods the body with cortisol and inflammatory cytokines.
Which causes more inflammation.
Exactly. In autoimmune-like conditions, psychological stress is a known potent trigger for physical flare-ups.
It creates a vicious loop.
Yeah.
The disease causes massive stress, and the chronic stress signals the immune system to keep attacking the basement membrane, which obviously makes the disease worse.
That's exhausting.
It really makes you wonder if the next great frontier in treating conditions like lichen sclerosus won't just be found in a tube of ointment.
I think you're right. Regulating the nervous system, aggressively managing psychological stress, and breaking that cycle of isolation might prove to be just as critical to achieving long-term remission as the tapering protocols we've discussed today.
It's a powerful reminder that you aren't just treating a patch of skin, you are treating the whole system. So to our listeners, take this knowledge, advocate for your own care, and remember that managing the mental weight of a chronic illness is just as important as mastering the taper. Keep seeking out those aha moments. We'll catch you on the next deep dive.